Good afternoon to all. Welcome to everyone for the oral virtual presentation track 4. We have two judges and moderators. Dr. Yogesh Kalpunde is the public health researcher and member of the executive committee of Sangwaru, People's Association for Equity and Health, Ambikapur, Chhattisgarh. Dr. Rebecca Zachariah is an internal medicine and geriatric physician. She's the head of the distance education unit CMC Vellore. Now I hand over the floor to the judges and moderators.
Good afternoon, dear friends. Yeah, we'll take it off when I'm speaking. Thank you so much for this opportunity. We are really looking forward to your presentations this afternoon. I think without wasting much time, we'll go straight into it. I think we'll start with the first participant, that's Dr. Hein. Please go ahead.
Hello, everyone. My name is Dr. Himito. I am a general practitioner. I'm currently a student of IPGDFM 2023 batch. Today, I would like to present about my abstract paper, mainly focusing on telemedicine vital role amidst pandemic and political turmoil in Myanmar, which is a lesson learned from real-world experience. I would like to tell about the background of the situation in Myanmar. In September 2021, there is a pandemic together with a political crisis, which lead to a double crisis. At the time, there is a prosecution of healthcare provider, which lead the healthcare provider to seeking safeties, and there was a severe compromise in the national healthcare infrastructure. So what happened with these lack of infrastructure for the public or community? There is a lack of physical accessibility, which induce majority of the death, and people are suffering a lot. There's a lack of a lot of oxygen, which lead people to death, and there is a misuse of oxygen. The people who have oxygen doesn't share oxygen. The people who doesn't need oxygen use oxygen at the time. So because people have a fear and there is no guidance at that time. So this is a physical impact, but also there's a mental impact, which is a little bit more, that the whole community become fear about the anxiety and uncertainty that produced by pandemic, as well as the political crisis. There is a mental health disaster in the country, and many people are suffering from depression as well at that time. So the objective of this brief abstract paper is to show people that there is a telemedicine service at that time provided by the medical providers such as me, who was a little bit seeking safety in places. So we are not talking about the telemedicine bit platform at that time. We are providing telemedicine through a simple application like Facebook Messenger. So this is a case study of the two patients that I was treated at the time. There are a majority of the doctor who also provide and who have cases similar to me. So the first case I would like to talk about is a 65 years old gentleman. He has a long history of hypertension. He has been treating his hypertension for 10 years. And recently, a family member, a close family member of his, died with the COVID-19. And at that time, when you see the mortuary, there are many dead bodies piling up each day, and people are becoming more scared of the situation. After 3 days of the loss of his family member, he has loss of smell. So then no other symptom, but just a loss of smell. Then he noticed that he decided that he has a COVID-19. So then he feared the same anxiety coming in, piling up and he has no medical professional he can communicate or he go to. So he become very sleepless at night, and his body become very weak. He didn't eat for a few days. He didn't eat well for a few days. So there was a fear happening not only in himself, but also in family, fear about how to deal the situation. Fortunately, I have a communication with the patient and his family. First, when he received me, he has a little bit of relief because he has accessibility to a medical professional. Then we go through, discuss about his situation, and I do a more daily monitoring and checkup with providing some clear information about him, and he's recovering without any complication. The next case is a similar situation, but there is a 37-year-old. He's an obese man. He's a father of two. He lives in a conflict area. He self-diagnosis himself with the COVID-19 because he has a fever and cough. So he say I'm have a COVID-19. Then at the time he measured his blood pressure, it become because of the anxiety at the time he get like 200 and 100. So there is an anxiety leading to a high increased blood pressure because he was obese, and there is a majority of cases telling people like obese people with have a higher rate of COVID-19 death. So then he look at usually he searched for in the Google and he found this misinformation. Then he said that he will die within the next day, and he become more fearful at that time, and his fear is more more profound by this misinformation. When I have a telecommunication with him and we provide telemedicine service, first I need to make sure this myth dispelled. Then I alleviated his anxiety, and then I try to improve his health, physical health status, and he recovered within the 7 days. So from these two cases, what I can say is telemedicine service is play a very important role during this kind of crisis situation. And when there is a limitation for a medical provider to reach to the patient directly because of a lot of situation, and it transform a lot of, it become a vital tool for majority of the people. Even after that, there is a public health service transformation in public health service why people are providing EN care through this telemedicine service. It's become very familiar in the country. So it is a very important tool, and majority of the services are becoming more and more useful in telemedicine nowadays, especially not only in physical health, but also in mental health as well. These are some references of the picture that I'm showing my abstract paper. So I would like to end up with the one quote: of all forms of inequality and injustice in healthcare, is the most shocking and inhumane, which is by Martin Luther King Jr. Thank you for my brief abstract presentation. I would like to answer any question and answer. Thank you.
Yeah, Dr. Hein,
thank you for
excellent presentation. Yeah, wonderful. So, since this is, we are talking about equity in health, what's your opinion about using, telehealth facilities to improve equity? It's a wonderful effort in very difficult times that you use mobile health to reach out to patients. Do you think, mobile health can be a good tool to improve equity in healthcare, and how?
Yeah. So from my experience, I understand that telemedicine is one of the tools that can reach to more people. So majority of the young doctors will not work in a very remote countries area where they don't have a life like development of the life or many other things. Majority of us could have the who graduate will go abroad and work in a better environment, but this telemedicine tool can reach to the people. So even I am in a faraway place, I can reach the patient in the village. So this is one of the method that allow people to reach more and provide more services to the people. Although there are some limitation, if we have a primary health care, we cooperate with the primary health care together with the doctor who are in the hospital. We can create a system where we can reach to more people who are definitely need services. So I believe that this will allow people to create more equity in the healthcare services.
Thank you so much, Dr. Herman. That was very interesting. Just out of curiosity, you presented two very good case discussions, but just approximately during that time period of this, crisis with COVID, plus whatever was happening in Myanmar, do you know approximately how many patients you might have offered teleconsults to, and is it a service that you are still continuing to provide?
Currently, I am still providing the service. So I cannot, I can say the timing at that time, like September, around 40 or 50 cases reach out to me. So unfortunately, some case has my consultation can assess to the patient, but this is only me. But when we are working as a group of, I have a group of friends who also work the same thing, and they have many patients they are providing. So at the time, I think majority of the doctor are reaching to this. My primary aim is to create a qualitative study where we can reach out to the patient directly and get their information. So I also aim to do that in the future, so that we can show better result and more statistically method that can be applied to the research methods. But this is just a two case study. I think it's for a publication, it's just a little bit weak, but we need to tell the people that there is actually somebody who is working and reaching out to the people at that time in very difficult situation. Thank you.
Thank you.
Thank you very much for allowing me to present this information. Yeah, thank you.
We'll move on to the next presentation. This is presented by Dr. Dhananjay Mankar and Dr. Kshitij Pal on forging sustainable healthcare partnership, a case study of basic healthcare services and Seva Mandir in rural Udaipur.
Greetings of the day, everyone. My name is Dr. Kshitij Pal. I, along with Dr. Dhananjay Mankar, will be presenting Forging Sustainable Healthcare Partnerships, a case study of basic healthcare services and Seva Mandir in rural Udaipur. Across various sectors, be it public, private, or non-profit, we're seeing a new trend of utilizing partnerships. These mutually benefiting partnerships not only enhance the outcomes, but they also result in synergistic rewards. One such partnership is between Seva Mandir, which is an more than 50-year-old non-profit organization working in Udaipur, and Basic Healthcare Services Trust, a startup also functioning in Udaipur, Rajasthan. They have together established Seva Mandir Amrit Clinic. This MOU was signed in June 2018. As of today, this facility has evolved into a stable primary healthcare services. Now, this partnership of Seva Mandir Amrit Clinic offers a unique approach to delivering healthcare services in the hilly terrains of Kherwada block. This Kherwada block is located 70 kilometers away from the Udaipur, and it is characterized majorly by small hamlets occupied by the tribal population, where the access to basic healthcare services to government sub-centers and primary health centers is low. So the objectives of my study were to analyze the partnership dynamics between the basic healthcare services and Seva Mandir and how they operate Seva Mandir Amrit Clinic. I wanted to understand how and evaluate how infrastructure, logistical, and resource sharing aspects are being managed. What are some of the key milestones and the best practices that this partnership has achieved? And I wanted to assess the impact of the partnership on the tribal community members in the Kherwada block. So the methodology of my research was, it was a mixed method research design, which in the qualitative aspect included in-depth interviews with key stakeholders, and document analysis mainly included secondary data analysis from annual reports, internal reports from both these organizations. Talking about the findings. So basic healthcare services mainly acts as technical and administrative aspect in this partnership, whereas Seva Mandir acts as a social, financial, and integration aspect. So basic healthcare services has Amrit Clinic models running in other parts of Rajasthan, which is being replicated here, whereas Seva Mandir has a strong foothold in the community integration, and since it's an age-old NGO, so it has a strong financial backing from various national and international donors. So both these organizations have their unique USPs, unique strengths. They've come together to solve the problem of low accessible healthcare in the region. Talking about infrastructure, the main hospital building is being provided by Seva Mandir. The finances required for upgradation is also given by Seva Mandir, but VHS provides recommendations for improvement. When we talk about the human resource, the doctor and physicians are being recruited by VHS. Since VHS has other clinics running in different parts, so they also have these doctors who visit the clinic one day, but they're available on the remaining days for any emergency cases. And the Seva Mandir Amrit Clinic is mainly run by nurses. Now, these nurses are recruited by Seva Mandir, but they are being trained by VHS to handle all sorts of cases, preventive, primary, secondary cases. These nurses are able to handle. We also have health workers and project managers, which are being recruited by Seva Mandir, but again trained by VHS because they have expertise in it. Talking about the finances, so since Seva Mandir has strong foothold in community integration and it has various national and international donors, so Seva Mandir acts as a main financial aspect in this partnership. So for this year, it has granted 10,80,000 for all the operations. Remuneration of all the staff is given by Seva Mandir. Again, since VHS has other clinics running in the region, so it has great vendor selection. It is expert in the vendor selection and drug procurement. So this aspect is managed by VHS. So placing of orders, receiving the drugs and giving it to the clinic, all these aspects are managed by VHS. Since Seva Mandir has a strong foothold in community, so the outreach activities are managed by Seva Mandir. And similarly, audit is done by VHS and waste management done by Seva Mandir. And the MIS is being maintained and managed by VHS. So talking about the impact that this partnership has on the community, so we have seen an overall increase in the patient footfall ever since the partnership opened. We are also seeing more number of women coming to this clinic. So initially, since there was no access to basic healthcare services, and even the transportation was a big issue because it is a hilly terrain region. So now women are being empowered because of strong outreach activities and good word of mouth of the clinic. We're seeing an increased number of women coming up. These nurses and the doctor that visits, they are able to care for critical care patients. Tuberculosis cases are being managed very well in the region. The clinic and the outreach activities are extensively working on non-communicable diseases like hypertension and diabetes as well. And because of the good word of mouth, they are increasing in the catchment area. Patients are coming from beyond the catchment area in the clinic. They are also focusing on severe acute malnutrition in the region. They have detected various SAM cases and they have also recovery have also been noted. Besides this, ANCs and PNCs have been incorporated and the outreach workers focus on identifying high-risk pregnancies. Reproductive services are also being given. Last year, 29 MTPs procedures are carried out. C-sections are also being given. Infectious and non-communicable diseases are also being focused. And if you talk about the community outreach, around 63 outreach sessions were carried out. Another unique aspect of this partnership is presence of Bal Sakhis, which are similar to ASHA workers. They're also paid a performance-based incentive, but their target is way broader and the activities are much more monitored as compared to ASHA workers. Now, some of the key milestones that this partnership has achieved, it included non-communicable diseases, tuberculosis treatment, malaria awareness programs. The important aspects were like they have reduced the out-of-pocket expenditure of the tribal population, and they have also helped to deal with quacks like Bengali Babas and local nurses that were treating the villagers. So all in all, again, like since VHS and Seva Mandir, both of the organizations have their unique expertise. So they have come together and developed this partnership. So in conclusion, we can say that this partnership has effectively improved healthcare access in underserved rural areas. Open communication and collaboration between these organizations has been crucial for this success. They have efficiently managing all the infrastructure, logistical, and resource sharing aspects. The way this partnership is working, it can be replicated because it focuses on emphasizing transparency, adaptability, and shared commitment and resources. So it is a good model for replication. Thank you.
Thank you, Dr. Kshitij, for this wonderful presentation. So what are the larger learnings? I mean, you just studied two organizations working together. Do you think this has any learning in terms of scale up and improving equitable care in tribal areas?
So the basic idea of doing this research was that it can be replicated. So the way these two organizations have collaborated in sharing their infrastructure and resources, it is a good way that the other organizations can learn. Because now what we are seeing is mainly the government is focusing on public-private partnerships. But this collaboration showcases a new way in which we are seeing after COVID-19 a lot of new health tech startups coming up. And we know that a lot of NGOs in these remote tribal areas are doing great job, but they sometimes lack those technical skills or technical expertise. And this gap can be filled by these startups. So I think this is a great model and it can be replicated to reach those tribal areas or underserved areas where there are no current functional government facilities.
Right. The other thing I would have shown differently, this is just a comment, is it's good to show before after, and whatever data that you showed before after, you also need to specify over how many years or months this improved. So in terms of partnership, we at least I didn't pick it up whether over what period there was, let's say, increase of 22% in certain services. So that is one thing that I would suggest. If you could do that, it visually it gives better sort of perception. And one of the things you said that the number of diabetic patients decreased, and that you attributed to improved quality of care. So I was not sort of, I was not sure what did you mean by that. And if you can elaborate a little bit, that would be good.
So they are focusing on overall health. So their community outreach programs, they're not just focusing on detecting the patient, but they are focusing on complete continuum of care. So once these hypertensive patients or diabetic patients, they are identified, they are brought back to the clinic and their treatment is continued. And then they have another feature called as Balsaki, who continues to monitor them. So like it helps them throughout the process, even after they have been diagnosed, to see, because we see in these remote villages, these patients do not take medicines regularly. So that aspect, the continuum of care aspect, that's what I meant through that sentence.
You mean probably that there is home-based care that is being provided, that's why they're not coming to clinic.
No questions. Thank you.
Thank you. Thank you, Kshitij. Very nice.
Thank you. Now I would like to invite Dr. Dhinu K, postgraduate student, Department of Community Medicine, Regional Institute of Medical Sciences, Imphal, Manipur, for presenting his study on health literacy among general adult population of Bishnupur, Manipur, a cross-sectional study. Take over to you.
Good afternoon to one and all. I, Dr. Dhinu K, postgraduate student from Department of Community Medicine, Regional Institute of Medical Sciences, Imphal, Manipur. I am presenting a study titled Health Literacy Among General Adult Population of Bishnupur, Manipur, a cross-sectional study. Coming to introduction, CDC has defined health literacy as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. By improving people's access to health information and their capacity to use it effectively, health literacy is critical to empowerment. And adequate health literacy helps to reduce health inequalities, and so it is considered as an important determinant of health status. To our knowledge, there are limited studies which have been done in India regarding health literacy, and we couldn't find any studies done in Manipur regarding health literacy. Hence, we decided to do a study on health literacy. Objective of our study was to assess the health literacy of general adult population of Bishnupur district and to determine the association between socio-demographic factors and health literacy. Coming to materials and methods, we did a cross-sectional study from December 2022 to January 2023 in Bishnupur, Manipur. Study was done among adults of Bishnupur district. Only those who were residing in the district for at least 1 year were included, and those who were too frail or bedridden were excluded. Also, those households in which even after 2 visits no one could be contacted were excluded. We calculated the sample size using the formula n equal to z square pq by L square. Assuming 50% prevalence of adequate health literacy, we got a sample size of 384. Accounting for design effect of 1.5, final sample size was 576. We selected the participants by stratified multi-stage cluster sampling with proportional allocation. Data regarding health literacy was conducted using a validated structured questionnaire HLS EU-Q16, which was validated in Indian settings before. It had 3 domains, and across the 3 domains, it had 16 questions, which were to be scored on a 4-point Likert scale ranging from. The final health literacy score from the questionnaire was converted into a scale of 0 to 50 based on comprehensive general index of health literacy, and adequate levels of health literacy were defined as those with a score less than 25 as inadequate, those with score between 25 to 33 as problematic, those having score greater than 33 to 42 as sufficient, and those having score greater than 42 and less than 50 as excellent health literacy. Data was collected by house-to-house visits. After identifying the household, one individual was selected from each household, and the researchers conducted face-to-face interview in local language, and the data was entered using Google Form. After collecting the data, after checking for completeness and consistency, data were analyzed in SPSS version 26. Descriptive statistics like mean, median, frequency, and percentages were used to summarize the characteristics, and univariate analysis was done using chi-square test. Those variables of interest which had a p-value less than 0.2 in the univariate analysis were included for multivariable logistic regression, and those variables of interest which had a p-value less than 0.05 in multivariable logistic regression were considered to be statistically significantly associated with adequate health literacy. Ethical approval was taken from the Institutional Ethics Board, and during the data collection, written informed consent was taken and privacy was maintained. Confidentiality of the data was maintained during and post the study. Coming to results, we had a total of 576 participants. Half of them were females, and the median age of the participants was 43. Like 56.4% of the participants had inadequate health literacy, 32.8% had problematic health literacy, and only 1.8% had excellent health literacy. For the ease of analysis, we clubbed the health literacy categories into inadequate and adequate health literacy. So we had 89.2% of the participants having inadequate health literacy, and only 10.8% of the participants having adequate health literacy. Table 1 shows the multiple logistic regression analysis done for the association between variables of interest and adequate health literacy. Age, which was significantly associated with adequate health literacy in univariate analysis, was not significant following logistic regression. Education and occupation had a significant association with adequate health literacy. Those participants who had no formal education or educated up to primary or secondary or were found to be having less odds for adequate health literacy compared to the participants who had an education of graduate and above. And those participants who were employed had lesser odds of having adequate health literacy than those who were unemployed. Marital status and socioeconomic status were not significantly associated with adequate health literacy. And consumption of tobacco in last 6 months, any history of chronic illness in greater than last 3-month duration, or visit to a medical practitioner in the last 1 year were not significantly associated with health literacy. Whereas self-perception of health had a significant association with health literacy. Those participants who had a fair self-perception of health had 10 times higher odds of having adequate health literacy compared to those who had a poor self-perception of health. So our study concluded that 9 out of 10 participants had inadequate health literacy, being employed, having no formal education, educated up to primary school or secondary school, had lesser odds of having adequate health literacy, whereas a fair self-perception of health had higher odds of adequate health literacy. Hence, we recommend further study should be encouraged in other districts of Manipur also to get more insight regarding health literacy, and measures to improve health literacy targeting those who have lesser education, those who are busy with their jobs, and should be undertaken, as health literacy is an important determinant of health. These are my references. I would like to thank the interns who were posted in the Department of Community Medicine during the study period for their enthusiasm and efforts, without which the study would not have been materialized. Thank you.
Thank you so much, Dr. Dhinu, for that presentation. I have a question that pertains to language. First of all, what is the language that you talked about, the local language that the Google form was translated to?
Good afternoon, ma'am. Actually, we have Manipuri language here, known as Meitei's language. So we prepared the questionnaire initially in English and translated to Manipuri, and all researchers who went for collecting the data had a printed copy with them, and they talked to the interviewer in the local language. The Google form was in English only, so the interviewer asked the questions and they administered the responses in Google form.
So that is about the Google form when you did the face-to-face. But
Yes,
was there the survey tool that you used? Was that administered in the local language or was that in English?
Ma'am, the survey tool, they had both copies. They had like in English version and Manipuri version with them, and they were asking the question directly to the participants. So all interviews were done, all participants were approached face to face. So if the participant, there were some participants who were fluent in Hindi also. So for them, they could communicate in Hindi, and those who didn't know Hindi and English, we used the Manipuri version of the questionnaire to ask the questions.
And this was done by your own team. Was there
Yes,
a validation process in the translation?
Ma'am, we did a pre-testing. Actually, the questionnaire which we used was previously validated in Karnataka for the Kannada version, and ours, due to the time limit, we couldn't validate. We did a pre-testing of the questionnaire.
Thank you.
Yeah. So I think what Madam is referring to is whether there was translation, back translation done. There is a process.
Translation, back translation was done, sir. Yes, a translation, back translation was done for the consistency.
Yeah, yeah.
But that results actually, the Cronbach alpha and all we didn't calculate.
So that has to be mentioned, because the whole study sort of is based on that, and you need to convince us that that process are okay. I mean, rest of the things become secondary. So yes, that's good. And I need to understand. So what's the population on which this was tested? I was trying to get some sense from data, but it was not very clear. Was it rural population? Was it urban population?
So it's a rural population, sir. Bishnupur is among the rural.
Was 100% population rural?
Sir, actually they have we included 6 villages and 1 municipal area also. So comparatively, it's like the populate, even though it is a municipal area, it's towards the rural side.
Okay.
Included both so rural and urban.
Yeah, so that need to come out clear. I'm just providing some comments on your presentation. So that needs to come out clear, so that we are aware as to what is the population that you are dealing with. One of the things that I would also comment would be to show actual questionnaire, because all these are different questionnaires, so we are left in the dark as to what were the questions in this questionnaire. So don't assume that the reviewers will know the questionnaire in advance. So that should be one thing. That, but you pick up on a very important issue of health literacy, right? So what's your solution? I mean, what solution you would recommend to improve health literacy? I mean, what you did as a recommendation is like a broad recommendation that everyone needs to be educated or literate. But it's a very difficult problem. Having worked in the rural tribal area for 12 years, I know how difficult it is to increase health literacy. So give us an idea as to some program based on whatever you found. Now you found a problem. Now how would you solve it? Give us 1 or 2 ideas if you can, which would be locally applicable, and you think that would make a difference.
Sir, one idea which we all thought were whenever any healthcare provider has an opportunity, whenever you get a patient try to educate the patient more regarding the condition, so that we should be at every opportunity, like teach back strategy. We say whenever we see a patient in OPD, we should ask them whether they have understood and let them explain regarding the condition. That is like teach back strategy. So that's the one thing we thought about. And the awareness programs, like whenever we have any new initiatives, we should like we should develop the interventions in local language also, so that they will be more they will understand more. And another thing is, in our study we found that employed people are having like lesser chance. So that may be due to since they are busy, they may not be able to access the healthcare related information. So most of the job settings also, we should try, like the employers should try give an opportunity regarding health awareness sessions, and also we should target them also.
You reading, it's very difficult field. Increasing health awareness is way
Yes, sir.
difficult than just showing the content, because
Yes,
then the
sir.
next question becomes like, would people use that information? So there is huge no-do gap. All of us
Yes,
know
sir.
that you should wear helmet, but how many of us really wear helmet when we are on the streets? So
Yes,
good.
sir.
And I think I hope you would keep on working on this area and develop this, right? There are a lot of creative solutions in this space though. Thank you.
Okay, sir. Thank you, sir.
Next, I would like to invite Dr. Kaaren Mathias for her talk on exploring developing relevant and equitable mental health programs in North India. 5 questions we asked when co-designing knowledge with experts by experience. I will welcome Ms. Kaaren.
Namaste and greetings. My name is Kaaren Mathias. I'm a public health physician, and I've been working with the Emmanuel Hospital Association in Uttarakhand for many years, and I'm now doing that largely based in New Zealand. This is a presentation around work we've been doing around co-production, low literacy, to increase the equity and relevance of mental health programs. And I want to acknowledge all the people and organizations here in this first slide. I'm going to be talking about this project, which we started doing in early 2020, thinking about all the ways that we notice what we're learning and what we're doing well and what we're doing badly when we try to co-produce. So we decided as a practitioner group to talk about what we were doing. And the idea of co-production is that people with lived experience partner in designing, implementing, and delivering and evaluating healthcare. We were keen to look at what are the processes of co-production, and particularly how do we do that well with people who might have a more limited education, and how do we think about the power relations as researchers. This picture shows one of the workshops outside our office in Dehradun. And we were particularly thinking we want to co-produce because we know there's really good evidence that it means that healthcare is more people-centered, relevant, cost-efficient, innovative, and that there are really important benefits for participants in the process of co-production, and it increases equity. But we know that the people who are most likely to be excluded are those who are systemically disadvantaged, and those with limited literacy are particularly high chance of not getting to be part of the decision making. So this was work I was employed along with most of the others in this team with Herbert Paul Christian Hospital, which is one of the Emmanuel Hospital Association groups. We were doing this in Dehradun in Uttarakhand. And Buran's, the project we're working with, is one that is been doing a lot of work in community mental health in the last 10 years. We built on a participatory action research framework, and you can see here Rakal, who I know is at this conference, was one of the mentors who guided us in this first project that we did in 2019. And we were just discussing what works and how do we do a good process. So what we did was discuss 6 different groups that we had worked with of experts by experience, and each group had a task. And one of them, Group C, lasted for 2 years. It was a sort of ongoing advisory group, but none of them have a really long half duration, and we'll reflect on why that is, but also that was a bit of a disadvantage. So the kind of findings that we came up with were that there were 5 questions we needed to ask ourselves every single time we tried to go about co-producing. And so I'm going to go through these with some of the examples, but keen to acknowledge that this is a really, really brisk summary, and to do this well, you need especially time and reflection, and that's not going to be reflected in an 8-minute presentation. So one of the first things that we think about when we're forming a group to kind of collaborate with and co-producing knowledge is who's there. And we usually try to make sure that we include at least 2 of these axes of identity, that people should maybe be living in a basti or a remote village, kind of away from the centers of power, on the kind of edges of the empire. Because we're working in mental health, we try to totally include people with psychosocial disability, and sometimes carers of family members, people who are living with disadvantage, limited education. We also think about caste and religion, and houses that are headed by women. And we, secondly, the thing that we think about is how do we make a group work when you've got quite diverse social identities? And we have tended to use groups that are quite heterogeneous, partly because it's been really helpful having people, some of the staff in Burans, a number of them have lived experience, and some of them have started in groups just to almost like as catalysts, because at the beginning, like Rimjum here, people will say, I can't talk in front of people. I thought I'll say something wrong and embarrass myself. I'm illiterate and I don't know what to say. And this is one of the really big challenges, is convincing a group of experts by experience who have experience that we cannot possibly get without their support, that they've got things to contribute. So we do things like using pictures, using Rajma beans to do scoring, go outside and look for something that makes you think about tikono, or being well, and then bringing it in and discussing it, a little bit like photo elicitation. And when people do share something, we try to really elevate and notice their expertise. The third thing that we think about is how do we build relationships of trust within expert by experience groups? And it's completely important to take the phase 0 that Rochelle Burgess talks about here, that you take usually 3 or 4 or 5 meetings just to build trust and share people's stories. And once that's there, the group self-governs, and they make their own time, place, name, and all of that builds a level of trust. The fourth thing is recognizing that we're working with people who are in a place with very limited psychosocial care, and that often the group ends up offering psychosocial support as well as co-production. And so a number of groups have ended up having almost a dual function, and they agree on an alternate meeting. And there's a really lovely quote here about how the group often will end up supporting people who are in distress. The fifth thing is thinking about how to acknowledge the expertise. And I mentioned that we try to name and underline it, but we also, there's this picture here of Kisise Saat Kuchkare, and we had not put any bindi or bangles, and the women in the group like, this is crazy, you haven't done a good job, we don't know who these women are. And so underlining, we said, that's why we need you here. And so this has just been a real scamper through 5 areas of questions that we ask ourselves. And I'd really encourage you, if you have time, to read our paper, which has got a lot more detail. But here's 3 implications: that programs are more relevant, there are beneficial mechanisms for participants that also improve their own sense of well-being and health, and it's a really humbling process because you get great learnings as a team, whether you're a practitioner or research-based, and it's really important to keep being humble and keep asking how to do it better and keep reflecting on the process. So I'd love to hear some questions, and here's some details of the article in case you're able to join us. Thanks very much.
Kaaren, thank you so much. That was very informative. From a education standpoint, and I think these were very vital questions as we're looking at co-production of knowledge. In your experience, you talked about like the 5 questions and some of the challenges it brings. Can you tell us about the success of maybe one of your mental health programs that's worked using this process?
Sure. I can think of an example of the recovery tool that we developed with a group of women who were largely not literate in Dehradun. They were residents in Bastis and Mussoorie and Dehradun. And we had been using kind of Western constructs of recovery, and they didn't include any components about being active community members. It didn't include any components of being having a faith practice or a spiritual practice. And they weren't really talking about taking responsibility in your family or in your community. And so when we talked with these women, they said, if you're well, if you have some level of recovery from your mental illness, then you will have an active faith practice. You'll be part of a faith group. You will be a contributing community member and a contributing family member. And so we got these completely different domains of recovery, which were not at all evident in the Euro-American examples. And when we used those in communities, we just got much higher levels of engagement because it made more sense to the community, and the, I guess, more individual and Western type ideas didn't fit so well, and these worked a lot better, and we just got better engagement and ultimately results. So yeah, it was really evident that this was a good process.
Thank you.
Kaaren, excellent presentation. So one of the things, one of the challenges in running such support groups or co-production is the facilitation. And so I just wanted to know who facilitated these meetings.
So when we started with the Pooja, who is my colleague, and I had some meetings and kind of talked about what would be a structure, but then we actually had the facilitation by one of our community health workers. And we felt that it was important because they could speak more of the local dialect, use really good idioms and textured language, which would really connect to participants. They could use examples because they resided in the same communities. But I would say we had to do quite a bit of coaching because the hierarchies that are so evident, and when anyone's, teacher ji batao, we had to really work hard to try and get a level of equality. And that was also why it was useful to have some of our team who understood more what we were about. They'd done lots of workshops and they would share their own experiences, and it really kind of acted as a catalyst so other people contributed more.
And did you have any success having a patient facilitating these groups as such? Because in the Western context, usually these are run by patients themselves eventually. I mean, here we have a facilitator who actually acts as a seed and starts it. But did you have any success? I mean, it's hard in Indian context and especially in rural context. So I was just curious to know whether you had any success having a patient.
No, we definitely did. So the groups, they became, I mentioned that they had some level of co-production as a function, but they were also providing peer support to each other. And so the peer support group was being completely run by them, by the group themselves. They became there's a woman called Bubbly, and she just leapt into the leadership of the group, and that worked really well. So that was definitely our objective, and it happened largely in that group. A couple of the other groups, one of them developed psychosis, and that obviously didn't go so well. So, you have to be adaptive.
Great. And did you have any success running it for condition other than mental health, primary mental health conditions? Because in mental health conditions, they lend itself well because of the social support and discussions and dialogue that you have. But have you had other conditions like let's say sickle cell disease or diabetes where you had success running this?
So we've set up a co-production expert by experience group for people with disabilities. And again, I guess that is it's a kind of chronic long term, but in terms of it was around how to adapt a youth resilience program we were running in schools, how to adapt it for young people with disabilities. And we were actually doing that with the National Institute. And so we got some really good support from them. Yeah. And just in case I need to finish up, I just want to mention that it's quite late. I'm actually back in India in a couple of days' time, but I couldn't make it to the conference, so I won't stay to the end of the session. My apologies for that.
Thank you. Thank you.
Thank you, Kaaren. So now I would like to invite Dr. Swati Jha for her talk on the comprehensive cancer prevention, screening, and management program.
Good afternoon, faculty, colleagues, and students attending the session. My name is Dr. Swati Jha, and I run the healthcare program for Reliance Foundation. I'm a pediatrician and a public health expert by training, and a community health expert by my profession. Why a primary care cancer program? It is because of the sheer numbers, which are mind-boggling, the annual incidence, the yearly mortality. In addition, despite our technological advances, and despite that our healthcare is second to none, the outcomes after being diagnosed with cancer are so much poorer than in the other countries. The cost of treatment compared to earnings is very high for more reasons than one, and catastrophic healthcare expenditure is higher the lower down you are on the socio-economic scale. The Healthcare Outreach Program is a pyramidal program. On the base, community care, education, and screening is provided by workers at doorsteps. The middle layer is primary preventive care through our mobile and static units. These are essentially mini primary healthcare centers, which are manned by a trained team and fully equipped with point-of-care tests, basic equipments, and drugs in the pharmacy, which are based on the WHO Essential Medicines list. The top layer of the pyramid is secondary and tertiary care provided in person or through teleconsultations through the facilities available at our mother hospital. The cancer program rides piggyback on this program. The goals of the RFH Comprehensive Cancer Care Program are to sensitize, to educate, to screen, to counsel for further care, and to support a beneficiary through his cancer journey. With the help of technology-enabled access to affordable diagnostics, treatment, and referral services, reducing the cost and discomfort associated on the way. The screening team goes from door to door in the community, carrying out screening with an AI-enabled questionnaire, which is incorporated in the beneficiary's EHR. Risk stratification is provided by the application, supporting the health worker into providing relevant advice and counsel. Those who are identified at high risk are counseled for a visit to the nearby primary care center for a medical screening. A follow-up online counseling is also provided by the support team. At the clinic, a medical doctor carries out a medical screening. Our team has been trained by Tata Memorial Center and receives regular refreshers. Those needing a diagnostic test are referred to the mother hospital or other hospitals based on their personal preferences. At the hospital, diagnostic tests are carried out and oncologist consultations are provided. At our mother hospitals, the costs are totally based on the patient's paying capacity. For cancer, for beneficiary as he moves through the cancer program. Throughout the entire process, the same team which has identified him initially supports him. In the last 1.5 years, we have faced several challenges. Cancer has a negative intonation, there are cultural barriers, there is such a lack of space that a beneficiary is not able to talk about his sexual behavior or addiction in front of others around him. We have found ways to address these barriers and to go about our work properly. Since the program is not a standalone program, there are minimal additional costs. The costs are mainly related in those incurred in expenses on the screening equipments, on the point of care tests, the campaigns, staff training, follow-up care, and software and data management. In our small way, the program tries to impact individuals and communities, the health systems by decreasing the load on them, and public health in general by improving what we hope is their lifestyle. The next slide shows some activities that we have been carrying out in our communities. Last month, we celebrated breast cancer awareness, reaching out to more than 4,700 women across our communities. In the last week of May, we celebrated Oral Cancer Awareness Week and No Tobacco Week. We focus fanatically on those with risk for oral cancer because these are the most vulnerable population. These suffer the most from lack of equity in healthcare, and they are the most likely to fall prey to addiction. No mean role played by celebrities endorsing these carcinogens everywhere. Speaking about hardcore numbers, in the last 1.5 years, we were able to reach out to 94,000 individuals, of which 15,000 were found to be at high risk, and of these, 11,000 were able to be connected for primary clinical screening. Around 400 people were identified as in need of further care, and then they were connected as required, they were connected to secondary and tertiary care. In total, around 18 people have been receiving treatments for cancer through our program. If we just talk about oral cancer, throughout this time, we identified 335 individuals with pre-cancerous lesions. If these individuals follow our advice, we would have helped them save 74 lakh rupees. Which money they would have had to spend, suppose they had been diagnosed later at the usual time of diagnosis that happens. So the program is really an effective one. Next steps, we hope to expand to other geographies while making sure that most of the Mumbaikars are screened. We are training our health workers to introduce palliative health care for those who need it in the communities. And in the short term, we are planning to carry out an assessment of impact that can show us whether we are on the right track and to carry out pivoting as needed. Thank you.
Good afternoon.
Hi, thank you, Dr. Jha, for this wonderful presentation. One of the challenges, as you mentioned, that people get scared when you mention the diagnosis of cancer. So how does your team sort of circumvent it?
Yeah, so initially it was, we were in a fix about how to, tell them that they are at risk and then not to make them frightened. So now at the first stage, the team tells them that our doctor wants to talk to you and give you more advice regarding better cancer prevention. And the doctor will examine you and see if you need any further examination too. And so far, it has been working well now. Now we have more people actually turning up for the next level of screening. But these are the... Yeah, but there are some people who have flooded lesions, especially oral lesions, but they simply disappear because they're not willing to accept the diagnosis.
So the other thing is, cancer that way is a rare entity. If you do, home screening, and you're actually putting a burden of screening on them. So how many breast cancer or cervical cancers could you catch? Oral cancer becomes relatively easy to catch.
So now that you ask, we are treating 2 breast cancers and 4 cervical cancer patients. So yeah. But because we were focusing on these easily identifiable cancers, we were able to identify one thyroid cancer too. She would otherwise have, gone on undiagnosed, though thyroid is not a focus.
The other thing is just a comment that we all get very sort of we think that precancerous lesions would lead to cancer, but if you look at literature, that the conversion rate of precancer to cancer is not that high. I have worked for 10 years in rural cancer,
Yes.
so we and actually it actually backfired, because all those precancerous patients had a lot of anxiety, and they had to live with that anxiety, because many times we call it pre-cancer and we send them to a facility and they said nothing is to be done, we'll just observe you. So that creates a lot of anxiety, as I'm sure you're very aware of that. So that was one comment. The other comment I had is regarding screening for lung and prostate cancer. So again, there are no good guidance regarding what to use for screening for lung cancer and prostate cancer, especially with PSA levels now, sort of fallen out of favor. And prostate cancer is largely considered benign, most of the prostate cancer cases. So what was the method that you used for screening for lung cancer?
So, we have a screening question. The first level is a screening questionnaire, which is based on the WHO criteria, more than 15 years of smoking, 1 packet of cigarette a day, like that. So for lung cancer, the high risk only meant that they were smokers, so they needed to be counseled. So that is why at the first level, no person is now told that you may have cancer. It is like you have high risk, so we would like to talk to you further. And now that you talk about oral cancer, the issue with not doing the screening is that there are too many people who eat gutkas in our communities. So anxiety is there, but what we've realized that when we were talking to these 335 people, at least there is also a positive percolation in the people around them. So at least we hope that it will continue, that the person tells you that I will make sure कि मेरा बच्चा नहीं गुटखा खाए, या वो चाचा को लेकर आया है तो ठीक है, मैं दादा को भी बोलूंगा मत खाओ और पापा को भी बोलूंगा मत खाओ. See, public health is about doing 100 things to save only one person's life will ultimately be affected, but you have to work for the 1,000 people who may be at risk.
Thank you so much, Dr. Swati. Just one point of clarification. I'm not sure if I missed it in your presentation. The impact that you had, the data and the impact, that was over a period of how long? What was the time?
1.5 years. We started in last April. This program was initiated in April 2022. But before that, we have been carrying out, oral, breast, and cancer screening off and on as a part of our primary healthcare work. That is how we realized that we should focus on cancer too now.
For next presentation by Japmehr for Sandhu. It's on training, empathy, and intentionality, reinventing the bonded service policy.
If medical students were exposed to experiences which weave together patient sensitization and appropriate needs assessment skills from an early stage, we argue that it can literally train empathy and intentionality into their future practice. Perhaps this informal and voluntary method would prove better than the previously suggested mandatory bonded service model. 83,000 undergraduate students join MBBS every year in India. And their most widely quoted reason for joining medicine is their desire to help people. 83,000 undergraduate medical students a year, and the serious hands-on rotations only begin in their intern year. These remaining batches of 83,000 students a year, prior to that, channel their energy towards a deserving yet predictable endeavor to study, which will be sprinkled with a few clinical rotations involving one patient interacting with perhaps 10 students. 70% of specialist seats remain vacant at the CHC level. This obvious rural-urban disparity was sought to be addressed by launching various mandatory bonded service policies across India. However, as we all know, it has seen little success. The foundation of our rural health services was laid down by the Bhore Committee about 77 years ago. when acute infections dominated the health scenario. In view of the changing health scenario, it has long since been time to review the structure of rural health services and tailor medical education to meet their needs. Innumerable studies have previously been published showing a decline in empathy across the professional years of MBBS training. This decline in what we might even call the backbone of patient interaction was addressed by including nothing other than more formal training. But this predictably showed little improvement. Policies should desist from implementing its decisions to create huge number of medical colleges or coercive means like mandatory bonded services, because just as no battle has been won in human history by ill-trained armies, woes of the health sector can't be solved by ill-trained doctors. Instead, we should focus on innovative solutions and the celebration of those which have been effective. 83,000 undergraduate medical students a year, and only 7% go on to choose rural public service. Keeping in mind that the doctor-patient ratio is about 0.7 per thousand in India, and the most frequent reason behind the failure of any public policy or primary health issue is a lack of knowledge, would it not be ideal to have medical students cover up for both? 83,000 undergraduate medical students a year. Only 5.7% choose community medicine as their specialty of choice, and 21% have previously admitted to being clueless about the extent of their role in that specialty. So what if we could provide an opportunity for these students to rotate amongst NGOs or programs working in healthcare, not necessarily in the capacity to treat, but in the capacity to observe, at least in the capacity to identify the unmet needs, and perhaps even address knowledge gaps amongst the same masses that these programs serve. So this idea mainly comes from my own practical experiences as a medical student wanting to make the most of my time in training. My first experience was with the Himalayan Health Exchange run by Dr. Ravi Singh. And they bring together healthcare professionals and students seeking a career in global health to provide care to the underserved populations in some remote regions in Indian Himalayas and Indo-Tibetan borderlands. This expedition was in my third year, and I frequently consider this to be my jumping point into clinical healthcare. As a preclinical student before that, I had never even been to the OPDs in the hospital. So this was a unique experience for me that taught me firsthand how to provide primary healthcare. I had a supervising physician teach and sign over my written notes for each patient, and I served as a translator for many of the sites. My second experience that I'll be sharing here was at a makeshift clinic at Tikri border during the farmers' protest. This was a lesson in healthcare and its allied sciences during a time of crisis. How to do the most with the little that you have to make sure that the least you do is enough. Five Rivers Heart Association ran this clinic under Dr. Seva Mandir, working under whom I gained tremendous knowledge and leadership skills. There was a lot to focus on, especially the sustainability of health and treatment protocols, since most of the hypertensive and diabetic patients or protesters had either left their medications at home or were just not aware of how serious their condition was, especially given the agenda at hand considerably. This experience did wonders for my soft skills and patient interaction, how to get my medically competent recommendations or advice across to somebody who believes that they had just bigger fish to fry than taking care of their own personal health. That was something I learned from here. The third experience I'll be sharing is under the basic healthcare services in Udaipur, where they frequently run an annual rural sensitization program. My intention for going for this was to see what works in rural healthcare systems and meet the people who had made that possible. The highlight of this program was how it encourages reflection. There were small group discussions during the day, followed by larger discussions related to rural health in the evening, which aids your skills of needs assessment and concentricism. So as you see, there are quite a few overlapping themes in these very different three experiences. And it is these themes that play a role in truly understanding your work as a future physician while remaining empathetic and working with intentionality. Only a few instruments exist to measure empathy in the general population, like the Interpersonal Reactivity Index, Hogan Empathy Scale, Emotional Empathy Scale, but none of them relate to patient-caregiver situation. So the Jefferson scale of physician empathy was developed specifically to address this gap. Now, this is how they addressed it, how they came across, or how they came about making this scale, was that they used these metrics that they trained their students under to score high on the scale, which was role play, experiential exercises, self-awareness exercises, active listening practice, and patient-centered interviewing practice. Now, isn't this interesting? That does it not sound exactly like a mock volunteering stint? These are the exact notions that you experience and train in when you volunteer. So here's the theory. The causal variables in healing can be directly affected and hence trained by volunteering and travel. With 90,000 health NGOs in India, there cannot be a greater area of need, which would be more perfect in terms of providing exactly the type of interactive and example-based experiences that students seek in their preclinical years. Students can, of course, partake in programs like these by themselves and pursue self-development at an individual level. But if we go a step further, we can suggest an opt-in club of sorts. At the teaching institutes, have students rotate amongst feasible options for a few days and then choose one that they would like to pursue for the rest of their time in that club. Upon completion of that term, these students can present a project at their respective colleges with one recommendation from their side to their program of choice, which focuses on improving the quality of care being given by that program. Program or NGO, please keep in mind. This will provide accountability, help their peers' knowledge about the patient population, promote the NGOs and program themselves, enrich their cultural competencies, improve their capacity of adaptability, teach them reflection in action, help them identify felt needs rather than perceived needs, promote interdisciplinary action when they try to look for solutions. I mean, at this rate, I'll just run out of fingers. 83,000 undergraduate medical students a year could be developing their future physician skills and actively helping other people just like they intended to.
Thank you so much. That was an excellent presentation. Can you hear us okay?
Yes, perfectly.
Thank you very much. That was an excellent presentation. Two questions. One is those 3 experiences you talked about. When in your training period did you undergo those?
So, ma'am, particularly from my end, these happened during the COVID pandemic, because whenever we were told to take a breather and go back home for a month or so, and that was mostly when there was, like the first experience, it was mostly during when there was a question as to whether or not to continue training, because it hadn't reached India. It was still in China. So they hadn't suspended duties as such, but they'd suspended clinical rotations. And so when I talked to my professors, because I had this opportunity, they said, okay, fine, you can go because you'll only be missing in classes. And at that point, we didn't really think that they were going to suspend classes for the rest of the year. So I was told that you'll cover up, it's fine. And then the second experience at Tikri border was after the COVID pandemic had hit, but the second wave hadn't hit. So classes were suspended and they'd put out a call for people who had gotten their provisional degree, but not their permanent degree. And the third experience was actually just like 2 months ago. I've completed my MBBS and internship period now. So I was free to pursue.
You know, the points that you make about intentionality and empathy being taught, I think is so important. But what do you think about an opt-in model versus actually making it something that's quote unquote mandatory in the medical training in order to include as many of the 83,000 students as possible? What are your thoughts on that?
So personally speaking, ma'am, I think that whenever something is mandatory, and of course there'll be people who don't want to do something, they'll find loopholes in it. When you find loopholes in it, the integrity of the program goes lower and lower. Those people will try to share their loopholes on it. Like right now also for community medicine, we're required to follow through for at least a minimum of 3 months, but maximum of 12 months project at a local rural area. And I've seen my peers try to wiggle out of it, try to find loopholes in terms of not having to visit the area. The area itself is the same area that's been allotted to the medical students in third and second year. So they are sick of answering questions. And I just feel like the whole integrity of the program goes lower and lower. And the amount that it encourages students who actually want to do it by the book also goes lower and lower. They feel less motivated to do it by the book because they'll know that at the end of the day, it'll all get marked the same.
Yeah, that's excellent presentation, Dr. Japmehr. So one of the things would be, you said that make it voluntary. So what do you think if you keep it voluntary, what will happen? What percentage of medical students would go to rural areas? Just a ballpark,
So I think
based on your experience.
I would say from my experience, by the most recent experience of the rural sensitization program, there were about 20 medical students over there, and they'd only come in because the majority of them had come in, and they've admitted to this. I'm not making it up. They've admitted that they came in because it was in Udaipur, and they felt they'd be able to like enjoy Udaipur. But after the rural sensitization program, I would say at least 60% were very surprised to find that they wanted to work in that sector. Of course, they weren't sure whether they would be able to commit to it because it's just a 3-day program. They feel like they can't, understandably so, decide their entire life on the basis of 3 days. But it puts this seed of doubt, which having experienced things firsthand, that too because you wanted to. So you're more receptive to what you see, believe, hear, talk about. That sprouts and blooms into a stronger tree than what you would have otherwise pursued having read it or being told by institutional heads. So I think that it's going to make a big difference given that it's voluntary. If it were not, then it would be more in line of ये करना पड़ता है, degree खत्म करनी है तो करना पड़ेगा. That's different from, oh, I wanted to do this. Oh, I learned something. I went in with the intention to be surprised by something, and I was. And just the mark of 21% people not even knowing what community medicine stands for and does, only because despite having rotations in the same, I feel like that would also be affected by having experiences like these.
All right, thank you.
Thank you.
Move on to our final presentation by Dr. Rachel Immanuel. Work with me, walking the extra social mile.
Good afternoon, all. Today, I'll be presenting a practical experience in one of the peripheral units of Christian Medical College, ROSA. I'm Dr. Rachel, Senior Resident in ROSA. Our team include Mr. Pal Jabras, Training Officer, Dr. Shanti Danimans, Senior Professor, Dr. Viswajit Paul, Professor and Head, Department of ROSA. As we all know, diabetes is a chronic disease. And according to International Federation of Diabetes, 1 in 10 live with diabetic among the age group of 20 to 79 years. One of the complications of diabetes is foot ulcer. And it is most common cause for decrease in the quality of life and increase in the cost of care. Many are underdiagnosed and undiagnosed. Only half of those are properly treated and controlled, and the problem is massive. And it's truly a tip of the iceberg. Today, I'll be presenting few of our experiences with integrated care and service delivery system. What is this integrated care? Integrated care is an approach for people and communities that seek to identify and resolve gaps in care or resolve poor care coordination. It is people-centered health system. Multidimensional needs of the population are taken into account, and it is delivered by multidisciplinary teams working across the settings and the level of care. In this, we recruited 4 diabetic patients who are amputated more than 18 years of age. And the interviews were obtained at their home in the form of narratives. After the narratives were taken, the patients were asked to do a relational map. The narrative lasted for about an average of 30 minutes, and we analyzed the following themes. The theme 1 was experience with diagnosis. Theme 2 was the satisfaction with medical care. Theme 3 was impact of the disease. The age group of our patients are as given below. We had a female and 3 male. Coming to the first one, which is experience with the diagnosis. The sub-themes were inadequacy of the self-care practices and the awareness about the disease. What we found out was the self-care practices are dependent upon the social environment of the individual. When there is a change in the social environment, as given by the 35-year-old who did not find job in the local community and went to Bangalore, was not able to be adherent to his medication. The narrative goes like this. I went to Bangalore to find job. I did not get the medicines there. I was not able to take food as advised by the doctor. The 65-year-old was saying he was taking insulin from a nurse for the first 2 years of his diagnosis. And further, we also found there was a profound carelessness on the side of the patient with the information provided. And the narrative of the 65-year-old was, I thought what it can do to me. And the 45-year-old said that when he had neuropathy, he went to a local practitioner and he was given a native medicine for that. And he was on food restrictions for 45 days and he did not tell the medical doctor on this. And the 45-year-old, 35-year-old said that he did not get medicines in Bangalore. We, at the base of all this was a sense of resentment and lack of social support as evident by these narratives. I should not have gone to the lake to cut roots was the narrative of a 65-year-old. And the 45-year-old was saying, I have a brother, but he did not help me much. All of them had a nature of work that made them more prone for injury. Coming to the next theme, satisfaction with the medical care, the ulcer care and the professional boundaries and financial transactions with the subcategories under this. In ulcer care, we found that overall among the patients, there was fragmentation of the care and a general resentment from the side of the patient. And the professional boundaries, we found out the community comprehensive care can extend to certain level, and the hospital-based care at a primary and secondary healthcare center can extend to certain level, but beyond the threshold, there is a need for the specialist intervention. And afterward, there is a need for a lot of financial support from this tertiary care as well as the secondary care for a much coordinated care as evident by these, where the patient was given all of his bills for free, more than 10,000 rupees. The patient was asked to pay only 10,000 rupees. And the 35-year-old said that his surgery was done for free. all the participants were very grateful for the subsidized treatment and the care that was given in the integration of them to the society. Theme 3, impact of the disease. Under it, the subcategories were day-to-day life, the work life, and the emotions. All of them found that their life was very difficult immediately after the amputation of the foot, where they were trying to cope up with the disease, as evident by the 55-year-old saying, my life had become upside down and I have become complete zero. And 35-year-old said that I'm totally dependent on my mother. I don't want to be a burden to anyone. And in their work life, they found that the social help extended was of great help. The 65-year-old said that he was given a loan to set up his own business, and he paid the loan back 1,000 per month, and he feel good that he is able to do the work. The 35-year-old is in the process of teaching a vocational job. He asked what kind of vocational job he will be able to do. With regard to the emotions, the 35-year-old had a suicidal tendency. Now he has accepted. The 45-year-old is very grateful to his wife for all the care that she has given her. And the 65-year-old now has adapted to the situation, and he is able to do his work and doing even the cutting of the woods by sitting in his chair. After the narratives, we asked them to do a relation map. A relation map is a abstract thinking which makes the patient to think how much of the component of life is related to them and how much of these are affected by the disease. So we found a patient-centered, integrated, and comprehensive continuous care, which has a life course approach, will help these patients to get integrated back into the society and be an active member of the society as well. So we would like to conclude that the high-risk group and the vulnerable group needs better coordinated, innovative, and streamlined liaising between the primary, secondary care teams and the multidisciplinary teams in the tertiary care is the need of the hour for these patients. So these are a few vocational jobs done in RUSA. Thank you.
Thank you so much, Dr. Rachel, for that really good presentation. Can you tell us, in the process of this, we've talked about different experiences, were these done as focus groups, and what were some challenges that you faced?
No, it was not done as a focus group. It was done as narrative. Me and two of us went to each of the individuals' home, and we asked them to narrate the stories, like how they got diagnosed. We had an interview guide kind of to ask few probes in between to help them in narrating it as a story, and then we analyzed it as themes. It was actually a storytelling by the patient, how they went through the experience of their diagnosis and experience of finding the diagnosis, and how they walked through the 8 stages of the disease and how they landed up and what are the resentment they had, and how the social component had helped them in building their life back.
And was this a team that went? I didn't catch the beginning of what you said. Was it like a team that went and talked to these people?
Went. It was done by me and one more person. Two of us went, and the question was asked by me and was recorded by the other person. So, and the notes were also taken.
Thank you.
Thank you, Dr. Rachel. You said that there needs to be someone who needs to coordinate their care in the primary, secondary, and tertiary setting. So, who would provide that coordination?
I personally feel that the public health person has to do that. So, because they have a larger picture in mind, and they will be able to do it better. And at tertiary, it might be a specialized care, and there is no point of sending the patient back to the same situation which has landed them up to this. So a public health personnel will be able to do that in a very much coordinated way to take the patient, not just reference from the primary and secondary care, but then there should be monitoring and has to be done after they are referred back to their place. And yeah.
Who would be that public health person?
Sorry, sir?
I said, who would be that public health person that you are referring to?
A public health person is a person who has finished an MD community medicine or a master's in public health or a community health. Who has a much more greater exposure to all these things. Not essentially a doctor, but having an exposure of how people have seen have gone through the sufferings of all these things.
Great. And so what would, if you had to use the learnings from this program, where would you use this data for advocacy?
Can you come again? So where I would have used this data in forming policies that can help in forming a policy that can help in this kind of coordination that is a little more easier from CMC point of view. But then in a primary health center, when they have to refer a patient to a tertiary care center, especially for an NCD, it is such a difficult job that a patient has to undergo, the doctor has to undergo, and there is so many private practice that exists, which is literally out of order. And there has to be a policy, and the policy has to take all these into consideration and make a proper policy to have a coordinated referral and a monitoring back.
I would leave you with an exercise to see how you would use your data and your training in community medicine. How would you try and improve care of NCD care, or how would you plug this information into the existing NCD program? That's the thought I would like to leave you with. Thank you.
We conclude the session. I'd like to thank all the participants for putting in so much effort in making the videos and the PDFs. I would also like to commend all the good work that all of you are doing in your various fields to promote equity in healthcare in India. I would like to thank our judges for moderating the session. Thank you.